Welcome. I'm Carol Jenkins, Executive Director of Cystic Fibrosis Research Incorporated. The CF Discovery Series was developed in collaboration with Camille Wasowich, nurse practitioner at the Stanford CF Adult Clinic. This series is designed to make vital CF information accessible to the CF community. And before beginning, I'd like to note that no information presented tonight is intended for a patient's diagnosis or treatment. As always, we urge you all to work together with your healthcare team for your medical treatment. And tonight we're looking forward to our presentation on managing diabetes in cystic fibrosis. Special thanks to Genentech and to AMED Healthcare for supporting this important evening. Their support pays for the venue and the refreshments, this studio that we've constructed here at the Crowne Plaza in Palo Alto, and they pay for other costs associated with this program. Tonight's program is being filmed by Scott Wakefield. Volunteer Eric Martin is handling the streaming portion of this production, and staff member Joanne Davis is tracking questions from our online participants. We are live here at the Crowne Plaza in Palo Alto, and I encourage you all to ask questions, whether you're here in the audience or part of our online community. A special shout out to all of you who are in the hospital. We're so glad that you can join us. And finally, thanks to our volunteers, to both Jennifer and Sam tonight for serving the food and helping us with our cross-infection guidelines. Tonight, our speaker is from Stanford Medical Center. Dr. Tracey McLaughlin is the Assistant Professor of Medicine and Endocrinology. She received her medical degree at UC San Francisco, a master's degree in epidemiology from Stanford University, a master's degree in public health from UC Berkeley, and her bachelor's degree from Stanford University in human biology. Dr. McLaughlin is currently an assistant professor at Stanford University's Department of Medicine in the Division of Endocrinology and Metabolism. In addition to working with patients, Dr. McLaughlin conducts a number of clinical research studies related to obesity, insulin resistance, diabetes, and cardiovascular disease. Tonight, Dr. McLaughlin is here to talk about managing diabetes in cystic fibrosis. Please give her a warm welcome.
Thank you. Excuse me. Thank you, Carol. So it's my great pleasure to be able to talk to families and caregivers and patients about cystic fibrosis-related diabetes. I have a clinic that specializes in this, and I work closely with the adult CF and transplant group at Stanford, and have been for the past decade or longer taking care of a lot of these patients. We will go through the following topics in the next 40 minutes or so. We'll talk about the etiology or the cause of CF-related diabetes, which is different from other kinds of diabetes. We'll talk about the clinical significance and why it's important to control the blood sugars in CF-related diabetes, also different from other kinds of diabetes. We will talk about the prevalence of glucose abnormalities in patients with CF. And then we'll go through some of the new guidelines for screening and diagnosis of CF-related diabetes. And finally, we'll talk about treatment. So just an overview to put things into perspective. CF, as most of you probably know, is the most common autosomal recessive disease in Caucasians. Non-Caucasians can also be affected. Mutation in the cystic fibrosis transmembrane receptor gene, which is a chloride channel expressed on epithelial cells, which are the cells that line many of the ducts and linings of the gastrointestinal tract, for example, lead to production of very thick secretions with progressive obstruction and fibrosis of many organs, not only the lungs. We will be focusing on the pancreas, which you can see here is an organ behind the stomach, which has several functions. The exocrine function is the function for digestion. You can see here these little clear circular things are the ducts that secrete the digestive enzymes that are necessary to digest the food. These become disturbed in CF, and most of the patients eventually will end up on enzyme replacement. The other part of the pancreas, not so well appreciated, is the endocrine part. The endocrine part refers to these cells, these purple cells here called the beta cells, which secrete insulin in response to glucose elevation. And what happens in CF is that in the ducts, in the lining of the ducts, there become retained secretions, which lead to structural abnormalities. So they become distorted and expanded, and they start to extend to the adjacent endocrine cells, leading to impaired secretion of hormones such as insulin. So it's actually a structural disease, starting with the exocrine pancreas, that leads to diabetes and CF. This is a completely unique cause of diabetes. There's nothing like it. Even removal of part of the pancreas, which can cause diabetes, is different in the way that diabetes presents. Autopsy studies of the endocrine pancreas in patients with CF show fatty infiltration, fibrosis, distortion of the islets, which are the insulin-secreting beta cells, and a decreased absolute number of beta cells. Here's a picture of the pancreas. These pinkish things are retained secretions inside the ducts. There shouldn't be quite this much retained mucus inside the duct. These are the islets, and this is a relatively normal appearance, with at least of the islets. As the disease progresses, the islets can become distorted. Here's a very expanded secretion within the duct, and the islets are starting to become distorted here. And eventually there's fatty infiltration and scarring as well. So what happens is the beta cells can't make that first little burst of insulin, which we call the first phase insulin response. So when we eat, we make a very quick burst of insulin. And this doesn't happen normally in patients with cystic fibrosis. Even in the absence of diabetes, that first phase insulin response is lower than in non-diabetic patients. There also is a delayed insulin response to oral glucose. So one study showed a 60-minute delay in the peak insulin in patients who had cystic fibrosis-related impaired glucose tolerance, and a 90-minute delay in patients who were met criteria for diabetes. These patients are not completely insulin deficient. So if you look at a patient with CF diabetes, they look like what we used to call juvenile onset diabetes or type 1 diabetes, you know, a young, thin adult who has diabetes. Those patients, by the time they get diagnosed, they don't make any insulin. And they can have very severe consequences, one of which is called diabetic ketoacidosis. And when that happens, their body is overwhelmed by other substrates made by the liver, namely acids, that can provide energy for the brain. And they are in the hospital and they're very sick and they can actually die. This is extremely uncommon in patients with cystic fibrosis. We have had one patient who had this twice, and I think that is a case report. It's not published, but it basically doesn't happen. And we had tested that patient for autoimmune diabetes. So it's very rare. And the reason is that they make enough insulin to get by. There are other differences compared to other diabetes, which we'll get into in a moment. But it's also different from type 2 diabetes. So maybe your patient with CF might have a mother with type 2 diabetes. And that's a completely different kind of diabetes as well, which is related to making insulin that doesn't work normally. And they become very hyperinsulinemic, but the insulin is being hypersecreted to overcome the blockage in effective insulin action. And they're treated very differently. They respond to weight loss and dietary changes. And one thing that happens with a lot of CF patients is they get admitted to the hospital and the medicine team starts to treat them like one of these other kinds of diabetics. And they especially don't like it when they get placed on a diabetic diet. So it's important for everyone, especially the doctors, to understand the differences. And unfortunately, it's just not that well appreciated how different the kinds of diabetes are. But I wanted to show you this nice figure of the abnormalities in the insulin secretion. So you can see here, these are 34 patients with cystic fibrosis compared to some controls who did not have cystic fibrosis. And they were given a glucose tolerance test. So they were given a glucose drink. And here you can see what the controls did. Their glucose did not go very high and came down here. Here's what their insulin did. This is a normal response. The insulin goes up right after exposure to the glucose, and then it slowly comes back down. That's a normal response. Now, these are all the cystic fibrosis patients. So these are the ones who were normal glucose tolerant. So they weren't anywhere close to diabetes yet, represented by the squares. That's their glucose. It's still abnormal. It goes up right after they eat. And their insulin is actually, here are the squares, it's actually it's delayed. You can see that here's normal, here's a CF without diabetes. There's a delay in insulin secretion. And then as you get on to cystic fibrosis-related diabetes, as shown by the squares that are open, here's the glucose going way up to 250 and then coming back down. Now, for someone with a different kind of diabetes, to get up to 250 after a glucose challenge or after a meal would be unusual if the fasting glucose was normal. There's a correlation between how high your sugar gets after you eat and how high it is when you wake up. So the fasting glucose correlates with the post-meal excursions. In CF, you can actually see that this patient's starting out normal, and they're getting up into these very high glucose ranges, which is characteristic and typical for CF diabetes and different from other kinds of diabetes. And here's the insulin. Again, we're looking at the open squares. Look how little insulin is being made. So the first phase, the early insulin secretion is absent, and it's also a delayed response. Here is another picture, another study, kind of showing the same thing. But I like to show this because I feel like if people understand the physiology, they can treat the disease better and understand it better. So here's a glucose, here's a control. Here is a cystic fibrosis patient who does not have diabetes, and here's one with diabetes. So here's the sugar going way up. And this is what the insulin does. So here's the control, nice little burst of insulin coming down, cystic fibrosis with normal glucose tolerance. Their insulin is certainly going up. And here's a diabetic, a delayed insulin peak, much later than the control. Now this slide is one of my patients. This ended up being published. This isn't a very final looking figure, but this is a really dramatic representation of what the blood sugars do. So you can take, here's a non-CF patient who's eating breakfast and then eating lunch, and this is what their blood sugars do. They actually don't go above 130. They're pretty normal all day long. But you can take a patient with CF-related diabetes who has a very normal fasting blood sugar, and as long as they don't eat, they can be 80, 90, totally normal. But when they eat, they go up to here, over 250. This might be a little different from the one that got published, because the one that got published was eating all night, and he was up in the 350s all night long. Very, very dramatic. And so when you see a high blood sugar in the morning on a patient with CF, the first thing you think about was, well, what did you have at night to eat? And that doesn't mean you need to start them on Lantus or a long-acting insulin. That is probably food. They're very, very sensitive to food. But when the food effect goes away, the blood sugar will come back down to normal. Now, insulin resistance is the thing that's kind of the first abnormality that occurs in the adult onset diabetics or the type 2 diabetics. And there's a lot of debate about whether patients with cystic fibrosis have insulin resistance. Insulin resistance means that the insulin doesn't work well. And so the studies on this are mixed. There aren't very many of them really looking at it carefully, but some show a normal insulin sensitivity and some show decreased insulin sensitivity. Based on my experience, these guys are very, very insulin sensitive, just like you would expect from a thin individual, right? As people become obese, they become insulin resistant. But when you're thin or active, you're very insulin sensitive, except for certain situations. When individuals are sick, they become insulin resistant. And so when a CF patient is sick, and if they're studied at a time when they're sick, it can skew, the results of the study, which is why the studies, I think, are mixed. But when they're infected, they become insulin resistant, and they will require 2 to 4-fold or even more times their normal insulin dose because they're resistant to the insulin's effect, the insulin's ability to lower the glucose. Patients, when they take glucocorticoids, prednisone, they become insulin resistant. When the blood sugars are really high for a long time, which doesn't usually happen in CF, but say they were sick in the hospital for a long time and no one was really controlling their blood sugars, that shouldn't happen. The high glucose itself can cause insulin resistance, and then any other acute medical illness. And increasingly, data suggests that hypoxia by itself can cause insulin resistance. So CF patients are normally very insulin sensitive unless some of these things are going on, in which case they can become insulin resistant. Okay, so just to finish how CF-related diabetes differs from other kinds of diabetes. So there are these dramatic post-meal excursions in blood sugar despite relatively normal fasting glucose. They do not get diabetic ketoacidosis or DKA. They are insulin sensitive in the absence of other contributing factors, as we just discussed. And there is no need to calorie or carbohydrate restrict or lose weight. The goal for these patients is to maintain their weight, or sometimes they're trying to gain. So we try to match the carbohydrate intake with insulin as needed. We do not withhold food and carbs, which is what I mentioned frustrates a patient sometimes when they get treated like another kind of diabetes. So moving on to the clinical significance. So we talked about how we get CF diabetes and why it's different from the other kinds of diabetes. And now I want to talk about why we care about the high sugars, which is also different from other kinds of diabetes. So first of all, the mortality rate is increased in patients who are affected by diabetes. So there's a 6-fold increase in mortality in patients who have CF diabetes versus CF without diabetes. We don't know if the diabetes is causing that. That's an association. This was shown previously, and then there was another recent study corroborating that looked at 520 UK adults who had CF who had at least one hemoglobin A1C tested. So it's not all CF patients, it's patients who might have raised some suspicion about having diabetes because they had to have an A1C tested. But this study showed that an A1C above 6.5, which is in the very early diabetic range, was associated with a 3.3-fold increased mortality after adjustment for other risk factors compared to patients whose A1C was below that. So again, if they had compared them to all comers, not just those who were tested for an A1C, they could have even seen a higher relative risk. So there's clearly an increased mortality. Does that just mean that the disease is more advanced or that they have this medical stress from hypoxia and more severe pulmonary infections? That's leading to the hyperglycemia? It could be that. It could be just an association. And we'll get more, we'll address that a little bit more in a second. So this study showed that the survival was particularly decreased in females affected by diabetes. So here you can see the black bar. This is a survival distribution over age. The black is women who did not have CF diabetes. They're all CF patients. And the red are the women with CF who did have diabetes. And you can see a dramatic difference in mortality or survival in the women. The green and the blue represent the men with and without diabetes. Again, everybody had CF, and there didn't appear to be a difference amongst the men. Another interesting point from this study showed that patients who were diagnosed with diabetes without fasting hyperglycemia. So, we're going to do diagnosis in a minute, but you can diagnose diabetes based on a post-challenge glucose. So like after a glucose drink or after a meal, if the sugar gets high, you can get diagnosed with diabetes, even if the fasting sugar is normal, right? And I showed you those pictures of how the fasting can be normal. So it's kind of an earlier stage. So in the patients who were diagnosed with diabetes but still had without fasting hyperglycemia, so they still had a normal fasting glucose, 40% progressed to have fasting hyperglycemia over an average of a year and a half. And that's important because a lot of my patients come in with this presentation of early diabetes and they want to know, well, am I ever going to really need to take insulin? What's going to happen to this diabetes? But that's the average. So 40% progress over an average of about a year and a half. Okay, so So why do we care about it? We showed the mortality, in association. In the other kinds of diabetes, type 1 and type 2, we care about microvascular disease and we care about macrovascular disease. Microvascular disease is disease of small blood vessels and nerves that affect three main organs. One is the eye. So diabetic retinopathy can lead to blindness, and maintaining normal or lower blood glucose levels can dramatically decrease the progression of that by 70%. Now, does this happen to patients with CF? There are 3 reports showing that patients who have had CF diabetes for at least 10 years have one showed 15%, one showed 5%, and one showed 16% prevalence of diabetic retinopathy. I now have, after having seen these patients for about 13 years, I have 2 patients who have very early diabetic retinopathy. My gut impression is that they do not get it like the other kinds of diabetics. They are getting a little whiff of diabetic retinopathy. They are not requiring major laser surgery and going blind. And that is probably because for many years during the early stages of diabetes, their blood sugar is coming back to normal on its own, as compared to these other diabetics who can be high all night long, all day long. So